So in this podcast, I have with us Abishek Chandrasekhar. Abishek is a good friend of mine. He is a PhD student at IISc Bangalore. He has done his bachelor's from Anna University. After that, he did his master's from University of Texas at Dallas, and he has worked in Tata Advanced Systems. After that, and then he joined PhD. In IISc Bangalore, he is working on a fantastic project, and when you see the video, you'll like it. He is working on biomedical devices, which is useful for type 1 diabetic patients. His research is funded by MHRD, ICMR, and his work is highlighted in the recently G20 initiative or G20 summit when they visited IISc Bangalore. Recently, his project is highlighted among top 15 out of 150 projects via Imprint Government of India initiative. So tune in and see this amazing podcast. You're gonna like it. Abhishek, tell me about yourself. When did you join PhD?
I joined my PhD at IISc in 2019, August of 2019. I joined the Department of Cyber Physical Systems, and my field of research is optimal control theory for safety critical systems.
Okay, so it was after that, I think there was a COVID period. After
Yes.
how long it was COVID pandemic and everything was closed?
The March of next year, around 8 months after I joined, COVID hit, and then we were in lockdown for the next 2 years at least.
I think in IISc you do, since I don't know about Robert Bosch, you guys also have to take 4 courses for the PhD
Yes.
program. Yeah.
If you're a master's graduate, you have to take 4 courses. If not, you have to take around 20 credits of courses.
Okay. So you completed your courses in first semester itself, or did you?
It took me almost one semester, 1 year.
Okay,
the
so
first semester,
it means you didn't. Did you started doing the research during that time period, or you were doing only courses?
No, I started my research right after I joined in August itself.
Okay, so we'll go back. We'll go to your research soon, but
Okay.
Just I want to have this idea about COVID and all. You remember IISc imposed a lockdown for 3 months, and then we again
Yes.
joined. So how much it impact your research in that way?
For my research specifically, I need to go to the hospital a lot to test on clinical patients. So that impacted my progress a lot. So my research was pushed back by almost a year. So I just focused on theoretical aspects of it. Mine is very applied kind of research. It's not theoretical. But then I had to focus on theory only for 1 year because I had no choice.
Okay. So, but you were doing the work in a collaboration with Aerospace Department of IISc?
Not a collaboration. My professor is also associated with the Robert Bosch Center for Cyber Physical Systems. So our work has nothing to do with aerospace. It has to do with the field of control theory. So the concepts we apply to aerospace can also be applied here. Control theory is a very broad and versatile field. You can apply it to any field, including finance or biomedical or engineering. So that way we are using those concepts to apply to biomedical engineering.
So what do you think how COVID impacted India and the world in terms of tech? What do you think?
There's there's an interest in healthcare right after COVID. People realize how tech in healthcare can help people, how tech can enhance people's lives, because they realize how important healthcare is after COVID. Before that, there was not much interest in healthcare as such.
Yeah, and I think there was budget cuts, funding cuts, a lot of program which were for virus infections, and so also all around the world there was funding cut in that. But after that, again, there is like everybody right now want healthcare funding and all.
Exactly.
Yeah.
And they didn't expect that this would happen. Nobody ever thought that this would happen in just a short period of time and impact everybody's lives so much.
And go ahead.
No, that's what I was just talking about, the impact of tech in healthcare.
Okay. And apart from that, if you see, there are another thing also, like how I would say digital sector and tech sector, there was a boom in tech sector. If you see Zoom and all these company gained a huge amount of funding and all these things during that time frame. And later on, right now, you can see the impact of these tech layoff and all these things are happening right now.
So companies capitalize on the requirement for tech at home because everybody's stuck at home. They have to do something.
Yeah.
So all these big tech companies capitalize on it. They hire a lot of people, but then they should have known by now that this requirement will go down after the world goes back to normal. Nobody's going to sit at home forever. So after 2 years, when people started going back to office, then the requirement for these tech products became less. So that's why there are so many layoffs now.
I think they had a wrong perception in their mind. Even a lot of leaders, political leaders, were talking about digital 4.0 and all these things. They took it so seriously. And then the realization came when the COVID started going. Elon Musk was saying, come to office or I'll fire you all. Then a lot of companies started doing it. Definitely those who are hardware-based company, they have to come to offices and all.
But there's also a realization that people don't really need to come to office to be productive. Like especially in the software sector, a lot of people were more productive at home because the working hours are not fixed. When you feel like working, you work. The company doesn't care about when you work. As long as you meet their targets, they don't care, right? Targets and deadlines. So people have this realization, okay, I can work from home and be productive at the same time. For hardware, it's not possible, but for software, it certainly is.
And apart from that, I would say there was more work-life balance in the life of people. People started liking, I think. What do you think?
That's true. Yeah.
Yeah.
People realize that there's more to life than just work during COVID.
Even right now also, I would
Yeah.
say right now also, if you see a lot of industries are doing 3 days work and 2 days like off work from home, something like that.
Yes. And people realize how much of an impact it had on mental health as well. Working all the time.
Yeah, that's true. So even during the COVID, I won't say like COVID was beneficial in some or other way. It costed huge amount of lives. But I would say there was like, whenever there is such kind of, I would say,
an event
dip in the human civilization, there some innovation comes out of it. Even we have seen like how biomedical boomed during that period of time. Even your project got a huge amount of funding. We'll talk about that. But if you see, apart from digital platforms and all, like video call, Zoom call, and all these platforms, Gmeet and all these came, and they had very advanced features also. So they started earning from it. So let's start with your project. Our audience would like to know what you do the research on a broader perspective and how it impacts normal human life.
Okay. So basically, I'm from the field of control theory. Control theory is a system where you're trying to automate a process, basically. So everything from your autopilot in the aircraft, where the plane flies by itself, to autopilot in the cars, or even like any autonomous system or a robot. All these are control systems. So we are using those concepts in biomedical engineering. So in my case, what we're doing is we're focusing on type 1 diabetic patients. Type 1 diabetic patients are people who
What are type 1 and type 2 diabetic patients?
So diabetes in general, you must be aware that it is a problem with controlling your blood sugar levels, right? So type 2 is the most common thing. Type 2 is like your body's insulin production is not enough to control the blood sugar levels. You're more resistant to insulin, basically. So if you take 80 grams of carbohydrates, 90 grams of carbohydrates, for a diabetic patient, it's not enough to bring it down again. Whereas for a normal person, the amount of insulin that the pancreas is secreting might be enough. This is type 2 diabetes. This is the most common thing. But this is also not the most severe form of diabetes. The most severe form of diabetes is type 1 diabetes. Type 1 diabetes is like your body's own immune system. It attacks the pancreatic cells. So that it's not able to produce any insulin anymore.
Due to immunity response and all, or due to...
it's called an autoimmune condition.
Okay.
Autoimmune condition is like your immune system thinks that your own body is harmful and it attacks your own body. So there are a lot of autoimmune conditions. So type 1 diabetes is a result of another autoimmune condition. So your immune system attacks the pancreatic cells. So the body has no capability to produce insulin. It's not about whether the insulin is enough or not. The capability to produce insulin is gone. So these kind of people depend completely on external insulin. Otherwise, they can't survive. If you can't regulate your blood,
what are the percentage of those people right now in India who are type 1 diabetic?
So diabetes overall in India is around 74, 75 million people right now. And out of us, like roughly 10% you can estimate to be type 1 diabetic. So 7.75 million people are like type 1 diabetics.
Okay. And I think it's growing. It will keep on growing with time because of the, the way we are living our life with minimal,
So as far as I know, right now, China is the diabetic capital of the world, but India is increasing at a very huge rate. So we are already close to being the diabetic capital of the world. So the amount of people we have in India who are diabetic is very, very large. So there is a huge requirement for like proper healthcare treatment for diabetes.
Even if I interject here, even in US, I was reading on TEDx talk in which there are a lot of things which are related to diabetes, like obesity. When in US, obesity, there was a army journal who was giving a TEDx talk where he was saying obesity is a national, I would say, national security concern, because 24% of the youth, American youth, can't be hired into the army due to obesity issues. 54% of the youth can't be hired due to diabetes and other related issues, heart and all these related issue, and 60% can't be hired due to drug issues and all. So it's like a severe, we have
Yes.
seen in Western world, it's like it's impacting everything very seriously. So in India also, I think it's growing by huge amount. Yeah.
So there are a lot of factors to this. One of them is certainly being food and exercise. If you don't have proper food and you don't exercise properly, that's one reason. The other reason is also genetic. So if you're prone to it, your son or daughter might be prone to it as well.
Okay.
So, and then the rate at which it progresses is also faster. Suppose you have diabetes at 50, then your son or daughter might have diabetes at 40. That's how it keeps on progressing every generation.
Okay. So
Unless
apart from that, what currently type 1 diabetic patient used to do? What was their normal way?
So type 1 diabetes is very, like I said, it's a different case. It's not about the food or lifestyle or genetics. It's just your body attacking itself. So there's not really much of you can't prevent it. If it happens, it just happens. So these kind of people, right from like a young age, they have to take a lot of insulin doses. So there are two types of doses. One is called a bolus dose and one is called a basal dose. The bolus dose is to compensate for the amount of food you're having. Suppose you're having like breakfast or lunch or dinner, right? Right before the meal, like, or just 20 minutes before your meal, you just take a shot of insulin.
Every meal.
Okay. Every meal. That is called a bolus dose. And then basal dose is like for the rest of the time. When you're sleeping, it's a different rate. When you're just running, it's a different rate. So depending on the type of activity you're doing, you have to give another dose of insulin. That is for compensating when you're in steady state. Basically, like when you're just sitting idle or exercising, that is a basal dose. So these people can generally take like around 4 to 5 shots every single day, and they have to keep checking the glucose levels also, because based on the glucose levels only, they keep on changing the doses. Right? It's a factor of different things: the amount of food you're having, the amount of exercise you're doing, the amount of calories your body is burning, the amount of fat your body is burning also to produce more glucose. So there are a lot of components that are involved in this. So it is actually a very complex process. So doctors generally have a rough estimate as to how much a person needs per day. So every person's requirement is different, and every person's requirement every day is different. A person's body changes from day to day. So that's the two things. One is called intra-patient variability, and one is called inter-patient variability. Intra-patient variability is like the person's day-to-day changes, and inter-patient variability is like every person's person-to-person difference.
Okay, so there is a lot of variation related to among the population, I would say. Yes. Okay. And so it's a challenging research, I would say, for control kind of problems. It's a very challenging issue when you have variance across the population as well as within the population.
And race also has a huge role to play. Different groups of people from different walks of life have different responses. Like people in Africa may be respond different to people in China versus people in India versus people in the West. So right now, most products are targeted towards the Western population because the money is there, obviously. So they may not really work well for the eastern part of the world.
Yes, that's true. Even we have seen with the vaccines, a lot of vaccines were not working on South Asian people when it was like when it was related to Pfizer, even like the Russian vaccine. So it's like you are mentioning, like for country level, it's necessary to have your own technology in that way.
And in a country like India, it's even more severe because like we have so many variations of food habits and cultures and like working habits. People in the Northeast may be different from people in the North. People in the North may be different from people in the North. So everything is impacting this. So you have to study like on a very, very close scale.
Okay. So how did you start and what all things you are tackling? And let me let our audience know about what components you have and how you are tackling the problem and how it will affect when the product is ready.
So the basic idea is you have a sensor. A sensor is called a continuous glucose monitor. So it measures your glucose levels from the tissue level at every 5 minutes. So every 5 minutes it keeps telling you what your glucose levels is.
So you can have this sensor at anywhere in your body, or is
no,
there
generally
any particular
people
location?
put it in their arms or in their stomach. Arms or stomach, basically. So it's like a small coin with a small protrusion at the end. So it's not really painful. Like it'll hurt for like 2 seconds, like a mosquito bite, and it'll last for 2 weeks. So every 2 weeks you have to keep changing the sensor, and it transmits through NFC. NFC is what you use for payments and other things, right? Like for tap and pay. So it transmits data through NFC. So
it's like in easier way, some sort of like how we talk about Bluetooth and all these things.
Yes. Yeah. So currently there are sensors that are being developed for Bluetooth communication as well. The problem with Bluetooth is it drains a lot of battery, so it reduces the life of the sensor. Whereas NFC itself doesn't take too much battery power. So NFC is more efficient, and then it's also more secure because you have to be close to it to get the data. Whereas Bluetooth you can be far away and get the data, right? So security-wise, NFC is more safer.
Okay.
So what we're doing is
this is about sensor. What else components?
So the other main component is insulin pump. Insulin pump is like a small pager-like device, it's like the size of a smartphone, smaller than half the size of a smartphone. So it is programmed. It can be programmed to deliver insulin into your body continuously. So if you look at a type 1 diabetic patient, I told you that they take injections, right? But then your injections are like one shot. It's like one impulse, right? Your body doesn't naturally produce insulin doses in one shot. It produces continuously. It is a continuous smooth process, right? So the pump is designed to recreate that. Release small doses over a period of long durations. That is how the body naturally produces insulin. So the pump is trying to mimic that. The pump is capable, has a capacity to deliver 300 units of insulin in one cartridge, basically. 300 units is a very small amount. It might seem like a lot. 300 units is like around 3 ml. That is the amount of insulin a person needs over like 2 to 3 days. Per day, the person needs only like 40 to 50 units only. Or type 1 diabetes. Sometimes
but it depends upon what person is eating and how is his health, how is regular exercise schedule also.
Yes. So generally, on average, a person needs like around 40 to 60 units per day. So it will last. The insulin pump will last for a long time for each person. So 300 units of insulin will last you for like a few days, in fact. So it's a very, very small amount of insulin that's given to the patient. So precision is very important. Like the pump has to be very, very precisely engineered to be able to deliver that small capacity. So in most cases, the pump is manually programmed. So doctors look at your profile. The doctors look at the history from the sensor and then decide your doses. Okay, this person responds differently to insulin. So they set the doses, the bolus and the basal doses. So it's manually programmed. But the problem is it's not a feedback system. There's no information coming back to the pump. It's like, okay, you see the past and then you decide, okay, then this 1 week it was like this. The next week I'll program it in a different way. It's not an autonomous system. It all depends on intuition. It depends on a lot of doctor's intuition. The doctors have a lot of experience, right? So based on that, they decide the doses for each patient.
Okay.
But then it's up to the patient. We don't know how the patient is going to respond to it, right? So that's why the need for a closed loop system came into being. So
you mean to say where control system you were mentioning in the initial phase, you are linking control system to currently what sensors and pump already exist and how doctors are utilizing it autonomously.
Yes, exactly. So this is we're calling this a biomedical control system. There are a lot of advantages and disadvantages to biomedical control systems. The disadvantage being that the body is very complex. It's difficult to capture how the body reacts to different things, right? So that is one challenge.
You mean to say the adaptiveness of the control system or the state of the art control system, it will always lag as compared to the adaptivity and the complexity of biology.
Yes. Okay. So for example, if you look at an aircraft, for example, it works on Newton's laws. I mean, it's not exactly Newton's laws, but it's an approximation of Newton's laws. So we understand all these basic things from high school mathematics also. So we know how the aircraft stays in the sky. So with that knowledge, we're able to control it properly. That's why the aircraft is so smooth. It is so safe because we know the physics behind the aircraft. Similarly, the field of control theory, people who are specializing in biomedical controls, they're trying to make a mathematical model of this human body and focus on one subsystem. So I am focusing on the glucose regulatory phenomenon of the body. So how does a natural human being control blood sugar levels? Like, for example, when you have food, how does that food come into the bloodstream finally? How does it get digested? All these phenomena are being mathematically modeled. Of course, it's an approximation. You're approximating all these behaviors. But then once you understand this phenomenon, it's easy to control. But that's a huge approximation. So if there are 1,000 variables, it's approximately to like 20 variables.
So in physical systems, I would say the number of variables could be very less as compared to a biological system. Yeah.
At least the major components are very less. The major component, you may not know everything, but the major components in a physical system is very less. And the other challenge in biomedical systems is the availability of information. In a physical system, in aircraft, you can measure like hundreds of variables. You can measure like how much it is tilting up, how much it is going forward. Whereas in the biomedical system, how do you measure anything? You only have one sensor right now, which gives only one variable. So with that, you have to estimate a lot of things. Assume that a lot of information can be estimated based on one variable. That is
Apart
one more
from that,
challenge.
there are some policies also related to the extent to which you can test a biological being. Yeah.
Yes. And another thing was this variability. Like if you build 5-10 aircrafts, there'll be a small difference between each aircraft. But 5-10 human beings is very, very different compared to like 5-10 aircrafts, right?
Yeah.
So that challenge is also there. So this is all the disadvantages. There are advantages as well. The advantage is the biological systems are designed to be more robust. So even if you give wrong doses or something, the system itself is designed to be very robust.
Okay.
Like it can handle a lot of unknown things. And it's also a slow system. In aircraft, everything is in milliseconds. Here, everything is in minutes and hours. So every response takes minutes and hours. So you have a lot of time to make corrections or compute doses. So we can make use of that to give very powerful algorithms that you can't really use in other fields. In spacecrafts and rockets and robotics, you have to be very, very fast in computing your commands, right? The control system commands. Here, you can take your time to compute because there's a lot of time gap.
Okay.
So these are the advantages of biomedical systems.
What about how you are connecting sensors, the pump, as well as algorithm? What would be the entire, I would say, stack? How it works?
So ideally, what you would want is like you would want the sensor to communicate with the pump directly because you want to minimize the number of devices that the patient has to carry. But then like that requires a lot of collaboration between the pump and sensor companies. So there are very few companies in the world that make both the pump and the sensor. So Medtronic is a company in the US. They have this system where they make the sensor and the pump. The sensor communicates to Bluetooth through the pump directly, and they form a closed loop. and the pump computes the insulin doses required based on the sensor values. But then in most cases, pump manufacturers are different, and the pumps are very, very computationally frugal systems. They don't have much computational capability. They are designed to just focus on controlling the motor. They don't decide how much insulin doses to be given, right? So the computational capability of pump is not also much. So now, what one quick fix is using a smartphone in the place of a brain. Basically, the smartphone acts as the brain of the system. The smartphone gets the data from the sensor, it computes the doses, and sends the information to the pump.
Okay, so it's like if I want to, summarize it. So a sensor will measure the blood glucose level from the epidermis tissue or whatever the tissue is, and then it will send that information to a mobile smartphone. And there'll be computation on the mobile smartphone, and it will send the information to a pump how much insulin need to be released in the body.
Yes.
Is there any feedback from the pump, like is it released or not, and how much is released? How much control you have in the second process?
So if you have a collaboration with the pump manufacturer, it is possible. But right now, it is a hack. So we don't hardly have a collaboration with any pump manufacturer. We are trying to collaborate, but then right now, it's just like we're hacking into the system and then telling it what to do.
Okay.
The pump itself is not designed to be commanded externally. But we found a way to do it. And there are other people who are doing this. There's a project called the Open APS project. It's an open software where people have figured out how to use smartphones to make the system autonomous. It's mostly hobbyists though. It's not like a professional endeavor where people are like working in teams and teams. It's like mostly hobbyists sitting at home who have some software knowledge or some biomedical knowledge. They sit at home and they program themselves. And most of them are diabetic patients because they want a closed loop system. They program it themselves. But from this, a lot of research also has been done parallelly. Right now, the most famous ones are in the University of Virginia, where they have made a certified artificial pancreas system. Harvard is another university, and then one university in Italy called University of Padova, as well as Cambridge in the UK.
So they are working on the same project. It means like in the similar direction. How means like they may not be the control part of it. They may be biologist and all. I believe.
So University of Virginia, the algorithm itself is very heuristic. Heuristic means like it is not a formal method of control system. they focus on they focus on experience. The doctors have a lot of experience, right?
It means
Based on that,
if else
not
loop.
FS, similar to FS, but a little more advanced.
Okay.
But they focus on mostly doctors' experience to design the control system. Whereas Harvard is following a more theoretical approach, like control theoretical approach, where you mathematically model the system, you predict forward in time. So, and even University of Padova in Italy, they also follow a very mathematical approach. You can take different approaches, but as long as it works, the patient doesn't care, right? What method you use, even if it's not formal method or even if it's heuristic, it doesn't matter as long as it works.
Okay.
So, what our approach is our approach is very theoretically strong as well. It is based on optimal control theory. Optimal control theory is almost 100 years old. It is mainly designed for missiles and satellites. Missiles, how do you target something from a different country?
You mean cruise missile?
Cruise missiles or ballistic missiles. How do you design the trajectories for those missiles? Similarly, we're using the same concepts for designing trajectories for the glucose to follow. At what path do you want the glucose to follow for a patient? Okay. That is the field of optimal control theory.
You mean to say it's act as a tracking system also? It tracks the blood glucose level and it try to match it properly.
The clinical trial process takes over 1 week. So on day 1, suppose the patient is admitted, you put 2 sensors to the patient and then you send them home, because the sensors take around 2 days to calibrate to the correct values. The first day the values are not just a garbage. So after 2 days the patient comes back to the hospital. We check the sensors and we unprint them in the evening. So the next day morning, we conduct a test called the mixed meal tolerance test. So this test is to identify the patient's behavior to food. That is the first test. It's not to control, but to identify the patient's behavior. So every patient that comes in, they're given 80 grams of carbohydrates, basically. It's a standard meal. It's called Ensure Plus. It's a standard meal. If you have 80 grams, it has exactly the amount of carbohydrate that you're claiming it has. And then you give them a specific shot of insulin in one shot. Then you collect blood samples for the next 3 hours, every 5 minutes, every 10 minutes, around 25-30 samples. And those samples are analyzed to give you blood glucose and blood insulin values. Basically, you want to see if a person takes in food and takes a 1 shot of injection and the insulin through the skin, how does it appear in the blood finally? So basically, you want to see the response of the patient to insulin and food as well. So with this information, we can create a mathematical model for the patient. And this information also helps in calibrating the sensor. Because you're analyzing the true blood values, you can analyze the error in the sensor from the measured value, from the sensor to the blood values, right? So that error also you're finding out. These are the 2 main things. So with this information, we are trying to identify the mathematical model. So then we send the patient home again. Then I get the data in the evening. With that data, I will design the mathematical model first, then correct the sensor errors, then try to design the algorithm. This takes around 2 days of work for each patient.
How many tests?
Then again,
okay, go ahead.
This is all simulations on the computer. Then after 2 days after verifying the algorithm on a computer, then we call the patient in again on the 4th or 5th day. The patient comes in and then the patient is given the same amount of food again, but the insulin dose is given to the pump, where the pump will decide every 5 minutes what has to be given to the patient.
Okay.
Then we'll test the response. With that response, we'll claim whether the algorithm is successfully doing what it's supposed to do.
Okay.
This is how we test on every patient. So it takes around a week. So far we've tested around 10 patients, the closed loop setting. Overall, the project has been tested, has had 57 clinical trials, but 47 of them were for identifying the mathematical model. The last 10 were the closed loop system, which is what I was involved in.
Okay.
I was not involved in the initial studies. I was involved in the closed loop systems.
Okay.
So it's a fairly a rigorous process, and it's also painful for the patient as well. You have to draw a lot of blood from the patient, and then it's also 1 week of work. It costs around 70,000, 80,000 rupees for one trial. So it's fairly expensive and rigorous.
What about your funding? Who funded you, and what was the amount of funding and all?
So we got 3 rounds of funding so far. The first round was gotten before I joined the project. In 2017 August, they've got a funding from the Ministry of Human Research Development and ICMR, the Indian Council of Medical Research, for 3.6 crores. The funding was for developing the artificial pancreas system as well as developing an insulin pump in India.
Okay.
The algorithm was taken up by my professor. He is the principal investigator. And the other pump development was taken up by the Center for Product Design and Development in IISc under Dr. Manish Arora.
Okay.
This is the first round. And then that funding ended in around 2022 last year. And then we also had a CSR grant, a corporate social responsibility grant from another company for 25 lakhs. And now we've gotten a new fund for 1.5 crores for the next 2 years. It will start in a few months. This is from a private grant.
Okay. So I think a lot of money goes into clinical trials and all, I believe.
Yes.
Yeah.
So because it's a very safety critical system, right? If it goes wrong, you can't risk a person's life. So testing is one of the major factors in the system. That's why people don't take the risk also, because it's a very dangerous system.
Do you pay do you pay those patient whom you are testing on some
we
money?
pay them for the time now, because they take time off their work. So roughly around 2,000 per day or 1,000 per day.
Okay. In US also, it's like if there are some clinical trials, like I'm right now, soon will be the part of the clinical trials on EEG as well as muscle memory connection, something like that. So they pay around for 4 hours, they pay $40. It's like 1 hour, $10, something like that. Okay.
Even here, the patient only stays for like 3 hours or something. That's all. He doesn't stay for the full day, right? So for the 3 hours, he gets 2,000 rupees or something.
And what about, you were mentioning there are some challenges also when you test the patient. Sometime back you were mentioning you told that patient not to eat anything in the morning. When you tested your algorithm, it was like behaving like an outlier. So you asked to the patient, he ate biryani in the morning.
So the patient has to be like in a control setting, but you can't control the patient's life, no? Ideally, they're supposed to behave like a normal person, not like very extreme conditions. They're like supposed to behave at a normal cycle, like have like food 3 times a day, or like do normal work. But then you can't control them. Ideally, you should keep them in the hospital for the whole week. But these people also have other things to do, and they also have a lot of. Most of them are like very low wage earners, so they have a lot of responsibilities that they have to take care of.
So you should pay them after the entire clinical trial. If you pay them on the same day,
we pay them after
they will eat biryani. Okay. Okay, nice. So right now, I believe, what is the target you have? Right, what till what time you have worked, and what all things are remaining, and what is the future projection and all?
So right now, what I would say that what we've done is like we've done 2-3 things. One is like establish the concept itself. So the method we're using, the main difference between us and the other groups is the algorithm we're using. So the algorithm we're using is very novel. It's not been done so far in the world. And then
I believe you had some amazing papers also. Recently,
we have published a few papers, but we are focusing only on the engineering side of the papers. We're not focused on the clinical side of the papers yet.
Okay.
So the main other thing is we're trying to customize the artificial pancreas for every individual person. Right now, it's like the one in the US that's being sold. It's just one algorithm for everybody else.
Okay.
But we know that it's not the case. I mean, it is a lot of work to customize it to every person. So we also have something called adaptive control. It is like a learning-based system. So it adapts to every single person over time.
Okay.
So that is one thing. And then the second, we've validated this extensively over like a lot of simulations. And then we've also shown proof of concept in the clinical trials, first in clinical trials.
Okay.
So the next phase is to go towards like, right now we only tested with the morning meal cycle. We need to go towards 24/7 operation because the person has to use it 24/7. And then we also have to get certification. So we need to do like 100 more trials to get certification.
Okay.
So it's like 3 years more of.
I believe it's a long project.
It's a long project. It's a long. People in the University of Virginia have invested almost like 10-20 years or something, and even in Harvard they've been doing it for a long time.
Okay.
We didn't go. The reason we were able to pick up so fast is because we didn't start at the same point they started. We used a lot of literature search and what currently is going on. We started midway. That's why we were able to make some progress. We didn't start from scratch and then try to do it from there.
Okay. So I believe, what is how will be the usability, and what would be the price of the product, and estimated price of the product, and what audience whoever funding you, they may have some idea in their mind what audience they are tackling and all. Tell me something about that.
So the problem is most of these people who are type 1 diabetic are also like not low income people. So, and the only pump in India that's available, only artificial pancreas system in India that's available is from Medtronic. It costs around 5 to 6 lakhs. And then it's not just the pump cost. The insulin itself is 900 rupees for one vial of insulin. So that is a recurring cost. 900 rupees for every few days.
Yeah, it's like.
And then the sensor is also 5,000 rupees or 4,000 rupees.
Okay.
It depends. But like the sensor is also use and throw. So every 2 weeks you have to spend 5,000 rupees.
Okay.
there's a lot of cost issues with patients.
Hmm.
So we are actually collaborating with the Amrita University in Coimbatore. So they've
Okay.
already made a low-cost penicillin pump. It's
Oh,
very low
that's
cost
nice.
compared to they made it for like 50,000 rupees or something. But
Okay.
they've stopped the project a while back. Now we are reviving the project again.
Okay.
So the target would be to sell it around 1.5 lakhs for the pump alone, and then maybe 50,000 rupees for the closed loop system. So
Okay.
it'll be like 1/5, 1/6 of the cost of what is there in the US.
Maybe government can subsidize and the price can
Yes,
go lower.
that's what we're targeting. And the Amrita University pump has also been animal tested already.
Hmm.
So the next round of testing is for the human trials. This is what we're going to focus on this project.
Okay.
So they're redesigning the pump to make it more powerful. This was done like a long time ago, 10 years, 10, 15 years ago.
Okay.
So we're reviving the project and making it work again.
Okay. So I believe how would be they will be having a sensor over here and where they will carry the pump in their pocket or something.
The pump is very small. It's like not even the size of this.
Okay.
So you can just carry it in your pocket and then you attach it to the stomach. So
Okay.
it is very it's easy to hide it. People want to hide it that they have diabetes. A lot of patients we see, they don't want to tell their employers that they're diabetic because they think they can't do work properly if they're diabetic.
Okay.
So nobody wants to tell it outside. That is one of the main reasons it has to be small. So the sensor itself will be here in your arm. It will be like a small coin, so you can't see it.
Okay.
And the pump also you can keep it in your pocket. So there's no visibility as such.
Okay. Okay. That's great. That's the incredible work you are doing. I believe you also took part in S20, also G20 summit, something like that. I saw your pictures. What was that?
Yes. So IISc had selected a few projects to showcase the G20 delegation when they came to IISc. So there were people from ISRO, DRDO, HAL, Bell, and a few projects from IISc, and our project was one of those to be showcased to the delegation.
Yeah. That's nice. That's nice. And what else means, like, what is your future projection? Are you trying to go into some startup and all? Because I believe there's a sufficient market of this product. May not be today,
Yes.
but 5 years ahead. And what is your opinion in that direction?
So there is a requirement because the lifespan of these people, right? This like generally 30, 35 years. They die after that. So with this pump, even without the closed loop system, just the pump itself has a huge impact on the patients.
Oh,
So there is a huge requirement, and these people are not able to afford it. So the cheapest pump without any closed loop system, just manually programmable pump, is around 3 lakhs. That is also too much.
yeah.
And thus they have to spend a lot on the going to the doctors because the pump has to be programmed, right? They have to go to doctors weekly. There's a lot of headaches for those people. So there's a requirement, and there's a lot of diabetic patients as well. So we are focusing on building a startup for creating customized, affordable APC, artificial pancreas system for people.
Okay, that's amazing.
The future goal.
That's amazing. And okay, so let's roll a bit and come to the main idea, which was how tech has revolutionized biomedical field. One was your project, which is called artificial pancreas system, something that is the name, APS. Okay.
Yeah.
And there are some other projects which I can see. Definitely, there was some project related to AI, which takes the scan of your I believe lungs or heart, lungs, particularly lungs, and they have this AI software on their mobile and they detect whether you are COVID patient or not. That was a part in IISc also. Is XraySETU, COVID-SETU, something like that.
Yes, and there was also something called Coswara.
Yeah.
Coswara was for analyzing the breath sounds and other things to identify whether you had COVID or not. So AI has a huge role in biomedical. Basically, because you have large amount of data. So these are so many patients, you have large amount of data. It's easy to pinpoint and say what the symptoms are correlated to what features. Basically, you want to find a map between like characteristics of patients to the disease and infection, right?
You want to create a function between input and output. And related to Coswara, I think it's related to breathing, coughing.
Yes.
I think that is a product by IEE department from, I think, Professor Ganpati, where they were taking sounds from patient who has COVID and who doesn't have COVID. They just need to breathe. I was looking at their website and it is like relative. You have to count from 1 to 10. That is just baseline setting. And then it will detect you. That was a very amazing project. I can see means like on their data set, they got sufficient good amount of, traction.
There's no requirement to buy anything also. Just use a smartphone for this.
Yeah. A wonderful website also they built. And apart from there are a lot of progress which are going in biomedical field. Even Elon Musk, if you see, he don't have experience in biomedical field, but since he is a physicist, he put his hands into Neuralink also.
Neuralink. Yes.
Yeah.
So Neuralink is a approach where they're trying to create an interface with the brain using small electrodes attached to the brain.
Yeah.
Create a communication with the brain itself.
Yeah.
But then this idea was not new. People have been doing it for a long time. So this is what they're basically doing is they're miniaturizing the sensors and electrodes and putting it on the brain directly. Because there are actually video games also where you can use your brain to control the video game. They put electrodes in your brain and then see what your brain signals is mapping to the controls on the screen.
I think it is much more related to, I believe, what are they doing on the robotic side. They have a very sophisticated robot which can insert hairline kind of electrodes which are 1,000 in number. That is their right now innovation.
Yes.
And they have shown in their, I believe, in the expo that how a piggy, they have shown in a guinea pig and how you can, create a muscle memory connection where even if you have paralysis, you can create that, you can create the signal from the brain and directly insert into the muscle and you can start walking, something like that.
Yes.
And there are a lot of work. Yeah, it has Alzheimer's and Parkinson's also, these kind of diseases also. It has, I believe it will be having some impact.
There is a lot of controversy regarding Neuralink because like some experts in the field disagree that it is as revolutionary as they say it is, or they think it's too dangerous to do this kind of approach. Because generally you would want a non-interventional approach, right? You don't want to introduce anything into the body. So that's why some experts are against it, some experts are for it. It's still like ongoing debate. Nobody's really sure what is the correct way to go forward.
But see, AI is already, digital world is already influencing us in some or other way. It's not just not physical, like how we interact with our smartphone, mobile phones, and how we interact with our watch, even Google Glass, AR, VR. These are some way not as physical, I believe, but Neuralink, I think somebody has to start working in that domain. If I believe later on we'll be like human and machine will be having interface, so that there'll be a lot of things which are going like, if you see this, I believe, have you seen the Shark Tank in this? There was a company, what was the name?
Yes, Neuphony.
Neuphony. Right? Yeah.
Yes. They were customizing, they were building helmets to identify mental health issues.
And actually, they were trying to get the brain waves. There are 5 or 6 different kinds of brain waves which are associated with some, like delta, alpha, disorders, beta, gamma. And so I'll tell you a very good story around that. So delta waves are when you sleep, you have a delta signature. These one have different frequency content. The maximum frequency content is gamma. So when you are super attentive, super focus, you will have gamma signature if you capture it via electrodes. So there was a study in Cambridge or Oxford, I don't remember right now. So what they did was, there was a monk, Buddhist monk. They tell him to sit there was a proper interior environment where they put an electrode and they tell him to do his meditation. He did meditation for around 3 to 5 hours. So, let's get back a little bit. So a normal human being reaches gamma stage for 50 minutes. Even if you take 1 hour of duration, you can hit peak gamma signals only for 10 minutes. That is the maximum attentiveness. But when they did for that person, which is a Buddhist monk, it was for the 3 to 5 hours. It was continuously in that stage. He was continuously in the gamma stage. Okay. So I think meditation do have some impact, improving your focus and all. That was there's one of the objective. Other objective was using those signals to see how brain is working. Yeah. Yes. There's a friend of mine who I was mentioning to you. So he's working using electro seizure detection. So when there are some people who get seizures, brain seizures, so he's working on those signals to see different patterns in the signal so that you can detect the seizures and all.
Yes. So there's a lot of research going on in this field because of data. Again, because of the availability of data. So there's also like a lot of, most of them focus on signals from the brain. Another advantage of this research is like you can focus on prosthetics. The main disadvantage of people who are amputated right now is they don't know how to control the prosthetic robot, right?
Yeah.
So if you establish a brain communication interface, then you can command directly to your prosthetic leg what you wanted to do.
Yeah. So that was one of the objective of Neuralink.
Yes. So I had one of my professors in my master's university. He was working on this. He's one of the experts in the field. They're using it, but they're not focusing on the brain interface, but they're focusing on using data from human beings to learn how they walk, and then try to mimic that using robotic legs, robotic prosthetics.
Oh, okay. That's amazing. Then, yeah, I believe like COVID was that dip which has made us realize that there is a huge amount of funding, and where we stay on physical technologies like aircraft, spacecraft is much more as compared to what we are doing on human body. Yeah.
And it's high risk, high reward also. There's a huge amount of risk involved in doing this research because you don't know whether it will work or not.
Yeah.
And if it doesn't work, it has a huge implication as well.
Yeah.
But then there's also high reward. Like once it does work, it can impact has a huge impact on people. So cancer research also. So cancer research, one of the main problems in cancer treatment is the amount of doses you give for chemotherapy. Chemotherapy is actually like very harmful to your body.
Yeah.
But then like doctors want to make sure that the cancer is gone. So generally they tend to give more chemo than that's required. So one of the applications control system is like, okay, how do you accurately decide what chemo to give so that you don't overdose or underdose? If you underdose, the cancer will recur again. If you overdose, it has other health implications. Your body is weakened. You're basically destroying your body more and more the more you give chemo, right? So precision control is one of the main fields of biomedical research right now. Basically, the brain is a control system.
Yes.
The brain is basically a control system that decides based on the sensor inputs are your eyes and ears and the skin, and the actuators are your limbs and what you do.
Yeah.
So that is what the application of engineering is a lot in biomedical research.
Even I believe there are a lot of things which are going in. Do you know this technology called CRISPR?
The genetic modification.
Yeah, genetic modification to cure some of the thing which you mentioned, like type 1 diabetes. So it has some genetic component. Maybe CRISPR right now, I don't know if CRISPR is successful in human beings or not, but I believe they were successful on plants. They were successful, I believe, on rats also. But I think they are like genetic modifications also, I believe, in future.
Genomics is a huge field with a lot of implications.
Yeah.
That itself is a separate field. It doesn't even come under like the kind of technology we're talking. We're talking about engineering aspects of biomedical engineering.
Yeah.
That is completely pure biology. Starting by DNA strands, RNA strands, and modifying it to prevent diseases. It's a more preventive thing. What we're doing is curative. Like if you have a symptom, how are you going to cure it? That is more preventive. Like how do you prevent the things from happening in the first place?
Yeah, that's true. But I believe there should be funding in both directions because later on means like these are some amazing advances. Even if you see DeepMind's protein folding has a huge impact on, I believe, in drug discovery and all. So protein plays a huge amount of role. Even our body's mechanism where DeepMind has decoded it. They say they have decoded it, how protein unfolds and all. It's like a group of amino acids folds in different way it gives rise to different kind of protein molecules in the body. And using AI, they have revolutionized it. I think not only AI has only the effect in how data processing side is the only effect right now. I believe sensor technology also is evolving in some or other ways.
Sensor technology is involving, but the thing is, like, it's not just about like how do I say? So till now, there's been a general assumption that okay, this is what is good for people, this is what is bad for people because the data set was small. But then the more data you have, even simple things like diet, you'll read online about different diets, right? But then diets may not work specific to everybody. Everybody has their own metabolism. So this is what people have realized in the last few years, that everybody's body is different. And you have to customize whatever treatment plan or diet plan or whatever you want to do. It has to be customized. Customized medicine is the future. You cannot no longer give take a small group of people, test it there and say it will work everywhere. So you have to customize it to a lot of people.
I believe means customization is in where there is a lot of variable. It's necessary to customize them because in human population, huge amount of variation. Even if you see even a small city, you will see huge amount of variation. I believe customization is the way ahead.
Yes, and you want to do all this customization with minimal effort from the patient, and you want to use minimal sensors. Nobody wants to wear like 5 different sensors or different sensors. With one as little information as possible, how do you maximize your model adaptability? That is what people are focusing on now. So there's a lot of research going on in this field as well.
Even in Neuralink, previously, conventionally people used to research in neuroscience using that. Have you seen that helmet where they have like 20 and 30 sensors on your brain, and it was like and they want to make it as short as
Small as
possible so
possible,
that you can insert it on the back of your head. So I think sensor miniaturization, data processing, and apart from IoT kind of IoT kind of technologies, these were like helping to create, I would believe, in what you call it in that way, human machine interaction or
Future my human machine interface.
Yeah, human machine interface. Okay. So I believe the best way, so for the audience, I believe the best way forward, I know means like you may be astonished by the research which is going on. The best way forward right now is to do proper exercise, have a control on your diet. Yeah. Yeah.
So this is one side of it. The other side of it is like building assistive devices. So this is all like proper biomedical devices, right? So one more way forward is like, how do you just give suggestions to the patient? Don't give any intervention or don't give anything, but you have your smartphone, which is very, very powerful for this day and age. It has a lot of computation capability. Just use a smartphone, nothing else. Build a suggestive app. Like what doses is the patient supposed to take? What chemo is the patient supposed to take? You would just like, for example, the Coswara app. Just breathe into the microphone. There's not much. You don't have to buy anything. You don't have to do anything. Just use this phone that you already have. Download an app, and it gives you suggestions as to how to improve your health. That is one way forward. That will impact a lot of people as well. Because there's not much required for the patient side, right?
Yes.
That is one way. They are called smart assist devices.
Even you can integrate, I believe, smart assisted device in your project also. For example,
we already had an idea like this where we decided, okay, what if the person doesn't have enough money to buy a pump? Why don't we just give suggestions as to what doses they can take if they want to use a pen? The insulin pen is like around a few thousand rupees, maybe. That's all. Just buy that and use a pen. So the app will basically take the values from the sensor and predict forward in time. Okay, what dose of injection should you take?
Okay.
So what algorithm does is it predicts forward in time. Every 5 minutes it predicts forward in time and says, okay, this is what is going to happen to you in 3 hours. So take this dose now to prevent that.
Okay. That's amazing.
It's not completely autonomous, but it is better than just taking blindly, right?
Yeah, that's true. Yeah. Maybe a mobile, a smartwatch may have those assisted technologies and all. When your blood glucose level, even you can integrate your work with smart assistive technologies.
We are doing that as well. We are also taking heart rate data right now to see how much of type 1 diabetic patient burns in terms of calories.
Okay.
So that if you burn calories, you lose glucose, right? So you can't overdose insulin to a patient and then they go into hypoglycemia. Hypoglycemia has severe complications. Like it can cause even a coma and cause death also sometimes if you are too low for food. Yeah.
If the glucose level are pretty low.
It's very low. Because your body has no energy and glucose is energy.
Even your brain means like brain acts on glucose levels. Yeah.
Hyperglycemia, high blood sugar has long-term implications. Hypoglycemia, low sugar has short-term implications. Like it can cause a coma.
Okay. What do you believe right now? Even if you see all the products, there is a huge amount of sugar into it. It's also degrading our health, lifestyle, and all.
So it's not just like the thing is our body is designed to crave sugar because sugar is energy. But then like we don't really use our energy anywhere. It just decays inside the body and converts it into fat. So your another problem is if the more sugar you eat, the more your body becomes resistant to insulin. So the insulin in your body does not really work well enough after a long period of time.
Okay.
So that's why type 2 diabetes is so huge. And one more disadvantage is diabetes itself is not classified as a disease.
Oh.
It's not classified as a disease. It's just a condition. But then like it has other implications. It causes other diseases like neuropathy, nephropathy. People have to have amputations because of diabetes because you lose
even people have heart diseases due to that. Cholesterol levels increases, diabetes and all. Yeah.
So a lot of other implications for diabetes, but even though the regulatory authorities do not classify it as a disease, it has a lot of implications like some of the disease.
So Abhishek, that's amazing. Thank you for sharing your knowledge and your research with us.
Thank you, man. Thank you for having me.
Yeah. Thank you. See you. Bye. For such amazing podcast and for more number of guests, I want you to support me by subscribing to this channel. See you. Bye-bye.